Good morning, all. We'll go ahead and get started with introductions as people filter in. Welcome to a very exciting lectureship this morning. It's the 2015 Huldrych-Kammer Endocrinology Lecture. For those of you who may not know, Dr. Huldrych-Kammer touched countless lives here in Portland and within the Providence system as a role model physician, a pioneering endocrinologist, a gifted teacher, and a lifelong learner. He came to Portland in 1949 and really very quickly arose as the city's most revered endocrinologist. He spent 30 years as an associate program director in the internal medicine residency program at Providence, Portland, and was also a professor of medicine at OHSU. Over the decades, Dr. Kammer trained hundreds of residents, fellows, and medical students who really benefited not only from his love of teaching, but also his personal example and passion as a lifelong learner and scholar. He also served as a mentor to his fellow practicing physicians. He published seminal works and contributed greatly to the modern era of endocrinology. So it's in his honor that we have this annual lectureship and have the wonderful honor of hosting this year Dr. Robert Eckel. Dr. Eckel serves as the Charles Betcher Endowed Chair in Atherosclerosis in the Division of Endocrinology, Metabolism, and Diabetes at the University of Colorado. He earned his medical degree from the University of Cincinnati College of Medicine and did his residency in internal medicine at University of Wisconsin, then went on in senior fellowship in metabolism and endocrinology up in Seattle at University of Washington. He is past president of the American Heart Association and co-chair the 2013 ACC-AHA Lifestyle Guideline for Prevention of Cardiovascular Disease and was a member of the 2013 Cholesterol Guideline Committee. Dr. Eckel has published more than 300 peer-reviewed articles, and his translational research pursues mechanistic relationships among various metabolic disorders, including the metabolic syndrome, obesity, diabetes, and cardiovascular disease. It's truly an honor to host him today, and please join me in welcoming Dr. Eckel.
Thanks very much, Laura. I'm going to kind of move away from behind the podium so we can get out and be part of your presence here this morning. I'm a little confused about this whole Providence system. I've learned a lot here just this morning about how this whole thing operates. And in fact, right before I came, I went back to my room because I realized that the Kammer lecture is actually tomorrow, but then the introduction today anyway. So this is grand rounds, and tomorrow's the Kammer lecture, and you can come to both. There's entire redundancy between the two. So I'm going to be talking about the same thing. So I'm really a preventive cardiologist, although I'm an endocrinologist by board training. My clinic is in cardiology. I have a joint appointment cardiology. My activities in the American Heart Association and with the guidelines really represent that aspect of my career. So as a clinician, I'm more of a preventive cardiologist, and again, with a joint appointment, but my science is really more basic in nature, trying to understand how body weight regulation is controlled in the brain and how that relates to how insulin action occurs in the systemic circulation in relationship to how fuels are stored versus oxidized. So body weight regulation is kind of where my basic science is. Anyway, today I'm going to talk about one of my favorite topics clinically because I think, LDL is pretty straightforward. We now have a new class of drugs, the PCSK9 inhibitors, which I've written a number of prescriptions for already because I see very difficult patients in terms of lipid disorders. And the HDL story is kind of at rest right now. We don't have any indications that medications that raise HDL are beneficial clinically. That doesn't mean they won't be. It just means right now HDL should not be the center of your attention clinically, despite the epidemiology. But this is something we face regularly in the clinic, is the hypertriglyceridemic patient. So I've titled my talk today, Hypertriglyceridemia, the most difficult lipid disorder to evaluate and treat, and I still believe this. And it's not like I got all the answers. I think the more you learn in medicine, the more you realize you don't know. So I think there's an atmosphere of humility that surrounds all of us in science and medicine that we need to remind ourselves of. Now, my conflicts or the duality of interest, ISIS Pharmaceuticals, not ISIS, I need to put pharmaceuticals after here. Yeah, bad name, right? But this company was founded 25 years ago. They're into an antisense technology, and actually they have one drug in the lipid space approved called mipamericin, which is an antisense RNA that blocks transcription of the ApoB gene. Anyway, it's only approved for severe hypercholesterolemia, the homozygous form of FH. So I have I'm a consultant for them. I have grant support for them at a basic science level. And Regeneron Sanofi, I played a fairly active role in that company's posturing of alirocumab, which is the newly approved drug by the FDA on July 24th. Those conflicts will not enter into today's talk in any way. And then on the right side are simply things like this that are CME-related medical education programs. All right, so why do I call hypertriglyceridemia the most difficult lipid disorder to evaluate and treat? Well, the common disorders are not single genes. And I'll come back to that in a few minutes when I'm going to talk briefly about the genetics of these disorders. So no longer, this concept that I learned in Seattle many years ago from Ed Bierman and John Brunzell was that hypertriglyceridemia, let's say a patient has a TG of 250 or 300, they either have familial hypertriglyceridemia or familial combined hyperlipidemia. And FHTG was not putting people at risk for heart disease, and familial combined was. And when they did genetic studies, fairly crude genetic studies in the 70s and 80s, ultimately the genetics seemed to play out as both being autosomal dominant. It's wrong. It's totally wrong. And I'm not being critical. I'm just saying the current science indicates this is not a simple single gene defect. Secondly, the acquired disorders are almost infinite. And we'll review those very briefly in a few minutes. Problematic in particular is the fact that clinical trials with triglyceride-lowering drugs have suffered. And they'd suffered in terms of design, the idea that people thought maybe fibrates were like statins, and no matter what your triglyceride was, you were going to benefit from a fibrate. Wrong. So unfortunately, design's been a problem. The number of trials is about a log-fold less than the number of statin trials. So we're not looking at a large number of trials in comparison with what was done for LDL-lowering therapies. And the results are hypothesis generating at best. And what I mean by that is after a trial is completed and you do post hoc analyses and look at subgroups, subgroups are not definitive. If the primary outcome was not met, but a subgroup was achieved in terms of the benefit, that is not something that should influence the practice of medicine, although I think it does. It really opens up a new hypothesis to be tested more extensively. And finally, I don't think we really understand the very basic science of this. Is it the triglyceride-rich particles, which are basically chylomicrons and VLDL, that confer the risk, and or is it the company they keep? And when we think about company, we think of metabolic syndrome kinds of phenotypes, low HDL, borderline hypertension, glucose intolerance, central obesity, et cetera. So lots of reasons why this is a problematic area clinically. Now, first of all, we got a problem in defining levels. I think we've all experienced this in the clinic. Fasting levels are variable. And in fact, if you look at the Handbook of Lipoprotein Testing published in 2000, what we see here is that the variability, biologic variability, meaning from one day to the next, is almost 30% for triglycerides, and much, much less for all the other apoproteins or lipoproteins we measured. But the monthly biological variability is still substantially higher than all of these components that we relate lipids to cardiovascular disease with. So lots of variability in triglycerides. And actually, Medea Abdel Maksud and I worked together. She's the mathematician and the biostatistician, and I'm just the lipid guy. But anyway, we looked at the San Luis Valley study, and she went through a very sophisticated analysis called the GAM analyses. And what we looked at is the relationship between triglyceride variability down here and actually coronary heart disease development. And that p-value is substantial. That means even though the triglyceride itself was weakly associated with cardiovascular disease outcomes, this log transformation of the variability over time was a very, very strong predictor. That means when you see triglycerides at 250 one time and 190 the next and 300 the next, and that variability itself in the San Luis Valley of Colorado, which is a mixture of Hispanics and Caucasians, related independently to very strong risk. And here are some of the other predictors: LDL, age, male gender, and log TG. The log TG, not very impressive here, but when it's multivariate analyzed, it does show up as a predictor. So population data are skewed, and I'll show several examples of that. And that means it's not a bell-shaped curve. There are more people on the right side than there are very low levels on the left. Thirdly, the relationships to coronary heart disease often do not relate to the extent of elevations. Now, you'll see plenty of data that say they do, but then you'll see plenty of data to say they don't. So notice the way I phrased this. Relationships often do not relate. That doesn't mean they don't, but often they don't. And what's a normal level? Well, everybody says it's 150. Well, newborn triglycerides are in the 40 or 50 range. And, if you look at young adults, triglycerides are under 100 in every walking well young gal or young guy. So 150 we've used to define a hypertriglyceridemic state. Or the current science is increasingly, should it be non-fasting values? We're not 12-hour fasted all that often in our lives anymore, are we? I mean, we're fed most of the time. And in fact, there's increasing evidence that the fed state may be more important. Now, what we have here is Get With the Guidelines data that looks at triglyceride levels in patients hospitalized with coronary artery disease in the U.S. This is work by Greg Fonarow and his group. Here's the lack of a bell-shaped distribution. Look at that distribution. It's skewed to the right. Many more people up here than way low down here. So there's the skewed nature of the data. But what I want to show you is 35% of people in coronary care units had TGs above 150. Now, remember that number. Here are the population data for levels of 150. Overall age greater than 20, 31%, men 35%, women 27%, Mexican Americans, da-da-da-da. Note here, African American patients, women and men both, have lower triglyceride levels. Very interesting, and it's occurred in sample after sample of people of black race. Now, what I'm going to point out here is this 35% prevalence is no different than patients in coronary care units with acute coronary syndromes. So is 150 the number we should be calling a elevated triglyceride? And by the way, remember, metabolic syndrome criteria do relate to 150 as the cut point. Now, what we see here is if you look at triglycerides in relationship to N-Haynes data, these are dated a bit, but the recent data aren't that different. And this relates to obesity, to waist circumference. So here are people with a normal BMI and normal waist circumference. Here are people with a normal BMI and a higher waist circumference. And here are people with both. Look at that number. It's around 30% on the average. So if you're a little more centrally obese, your TGs are a bit higher. If you're obese without increased waist circumference, it's a little less higher, but nevertheless, it's still around that 30% prevalence. So again, coronary care units, free living populations, and ultimately, even obesity and waist circumference don't impact levels all that much in terms of elevations. Now, the metabolic syndrome, you know it well. I've had the privilege of participating in a lot of guidelines that relate to the metabolic syndrome. I call the metabolic syndrome the elephant in the room, and these are the criteria that define it, needing 3 out of 5, and these need to be adjusted importantly around the world for ethnicity and race. So that's really important in terms of waist circumference. We all know that people from India and East Asia ultimately have much more risk in metabolic syndrome criteria for a lesser waist circumference. So this is not a simple tool to be used globally without adjusting for that. But look again here, triglycerides above 150. Now, I'm going to contend that 150 to 200 is not a cardiovascular disease risk based on the clinical trial evidence. And I'll return to that in the final part of this talk, where we're going to look at the clinical trials that have been implemented to lower triglycerides with either fibrates or omega-3 fatty acids. So again, metabolic syndrome criteria, TGs again defined at 150 milligrams per deciliter. Now, next question. So is hypertriglyceridemia a cardiovascular disease risk factor? Well, I think to begin with, we all must realize the inverse relationship between triglycerides and HDL cholesterol. So here, when triglycerides are high, HDL cholesterol tends to be low, and when triglycerides are low, HDL cholesterol tends to be high. Now, these are different groups of patients, normolipidemics, people with isolated low HDL here, isolated high triglycerides here, and high TGs and low HDL. But nevertheless, I mean, this is a pretty impressive inverse relationship that relate HDL to triglycerides independent of the level of either HDL or triglycerides. Now, this brings up criticism about the metabolic syndrome, because if we go back a couple of slides and we look at this, why should lipids count twofold in the metabolic syndrome where everything else counts one? Because of this impressive inverse relationship, ultimately you could say lipids should count one. So keep in mind, clinically, when you see high triglycerides, expect the HDL to be lower or vice versa. Now, there are some exceptions. I point out 4, and I try to teach this to our fellows and our residents and even many faculty. The exceptions four are sex steroids. Oral estrogens raise TGs and raise HDL. Alcohol ingestion, when moderate to high, raise triglycerides and raise HDL. Ultimately, active weight loss tends to lower HDL and lower triglycerides if you measure lipids during active weight reduction. And the fourth example is thyroid disease. People that are thyroid toxic have low HDLs and low triglycerides, and the hypothyroid patient tends to have higher HDLs and higher triglycerides. So those are the exceptions. But other than those four things, this inverse relationship plays out. Now, this is a meta-analysis of 29 studies where populations at risk for cardiovascular disease are analyzed. And here we're looking at years of follow-up after the coronary heart disease cases are evaluated. 10 years versus less than 10, no difference. Ultimately, sex, male, female, no difference. Fasting versus non-fasting, actually non-fasting maybe is a little bit to the left of the average risk, but here's the adjustment for HDL cholesterol. And without going into more detail, I'm simply going to indicate that that adjustment for HDL in men is far more important. And HDL in men carries the weight. And a very big unanswered question in women is why in postmenopausal women do triglycerides have a much greater risk for cardiovascular disease even when controlled for levels of HDL? Clearly an unanswered question, and I think it's an inquiry that just needs more just due in terms of the research approach to answering that question. All right, so now we're going to look just briefly at the data from the Netherlands that Bert Noorderschoort has repeatedly published. So what we're looking at here is myocardial infarction, ischemic heart disease, or total death here, and we're looking at levels of hazard ratios at levels of triglycerides for non-fasting TGs now. And these are adjusted for HDL on the right, and when men are adjusted for HDL, we see that not totally melt away, but it's really modified substantially. Keep in mind, non-fasting TGs. And I'm becoming an increasing proponent of non-fasting because that's where we live. We live in a non-fasting environment. The problem here is through calculations of LDL that are a bit flawed. But in addition, the guidelines, our recent cholesterol guideline is based on fasting values because there's not enough non-fasting data to make a strong statement for guidelines to report. But let's look at women now. Same things, myocardial infarction, ischemic heart disease, total death, and when adjusted for HDL, that slope has changed some, but it hasn't changed nearly as much as it had for men on the last slide. This is simply a case in point example that women continue to carry more relationship between TGs when adjusted for HDL and events than men do. And again, an inquiry that is yet to be satisfactorily answered. Now, are the triglyceride-rich particles themselves pro-atherogenic? Well, we know that hypertriglyceridemia causes endothelial dysfunction. Warren Capel in my group, former University of Washington grad who came to Colorado, we studied fenofibrate and its impact on triglyceride lowering, looking at endothelial function before and after treatment, and we clearly can improve endothelial responsivity after we lower triglycerides with a fibrate. So we know in the absence of modification, endothelial dysfunction is associated with hypertriglyceridemia. However, endothelial dysfunction is not atherosclerosis. It's simply a sign of vascular integrity or the lack thereof. These particles can be retained by lipoprotein lipase in the arterial wall, and there they can be taken up by macrophages and foam cells can be generated. And also hypertriglyceridemia is highly associated with a prothrombotic state. So these are all kind of things that make you think the particles themselves are pro-atherogenic. So Ruth McPherson in Canada, Ira Goldberg at Columbia, now at NYU, and I kind of developed this theme a couple of years ago where if we're looking at the vascular lumen, and here's the triglyceride-rich particle, and here's lipoprotein lipase, which is anchored to the endothelium where the hydrolysis occurs. There are two working hypotheses. The first is after LPL works, the triglyceride-rich particle is reduced in size, still has ApoB, and that can be taken up through the endothelial space and ultimately, basically eaten up by the macrophage with a foam cell generated. Now on the right is the idea that there are lipolysis products, part of a lipase reaction here. Fatty acids could be one, but there could be other molecules that ultimately induce inflammation, adhesion, and have procoagulant activities. And this is the lipolytic toxin hypothesis. So neither one of these may explain the entire relationship between triglyceride-rich particles and atherosclerosis, but these are the current theories that remain out there. Now remember, The company, hypertriglyceridemia, keeps are low HDL, more hypertension, more glucose intolerance, and central obesity. So again, this proves nothing. It's simply working hypotheses about how these particles themselves may relate to the atherosclerotic risk. Now, this story is evolving. If you look at VLDL that are produced by the liver, ultimately there are various forms. One form has ApoB100 only. Another form has ApoE on it. And another form has ApoC3 in addition to ApoB. And another form has B, C3, and E. Now, the presence of E may or may not confer additional risk, but the presence of C3 has gotten a lot of attention. So a series of papers have evolved that ultimately support the basic science behind C3, and here's the basic science. ApoC3 containing particles are increased in insulin resistant states, such as the metabolic syndrome and type 2 diabetes. C3 increases the production of protein kinase C beta, which then induces further insulin resistance. The ApoC3 genes increase by inflammation. It reduces triglyceride-rich lipoprotein metabolism and decreases the binding of these particles once they get back to the liver. They increase adherence of monocytes to the endothelium. They are chemokinic, if you will, and induce monocyte activation. And also, they enhance adhesion molecules on the endothelium. So this presence of C3 on these particles may, in fact, confer additional risk that's not represented simply by VLDL triglycerides alone. So here's the series of papers. A year ago, loss of function mutations in C3 are related to lower triglycerides and less risk for coronary heart disease. Another paper, the first paper from the NIH, this paper from, again, the Netherlands, loss of function mutations in C3 and risk of ischemic vascular disease, again, less risk. And then the most recent paper just a couple of weeks ago, antisense inhibition of C3 in patients with hypertriglyceridemia. So when this ISIS Pharmaceuticals technology of an antisense molecule blocks the transcription of C3, you reduce C3 content of particles, and ultimately these people have a marked effective lowering of triglycerides. So these are the therapies that are going to be 5, 10, and 15 years away, these antisense technologies. But they're really a platform that's being built very successfully by ISIS Pharmaceuticals. And I'm not promoting the company, I'm promoting the science that relates to modification of lipids favorably by this type of approach. So what are the genetics? I alluded to this before. The lessons that I was taught many years ago have not proven correct. Familial combined hyperlipidemia and familial hypertriglyceridemia are not single genes, but polygenic traits. And a number of polymorphisms have been identified that relate to hypertriglyceridemia. And by the way, the same kind of story is there for HDL. When a very sophisticated genetic analysis called Mendelian randomization was carried out for HDL a couple of years ago, ultimately what was found was if you look at genes that relate to HDL and atherosclerosis, there was no relationship in terms of genes that control levels of HDL and atherosclerotic cardiovascular disease. But when it was looked at for LDL, the multiple genes that relate to LDL, ApoB and microsomal transfer protein, and ultimately the LDL receptor, and on down the line, you could explain most of the risk for atherosclerosis for LDL based on the genetic profiling. Now, here's triglycerides, which is a story very much like HDL. So I'm not going to go through this whole list, but here's ApoA5, the glucokinase receptor, LPL, angiopoietin-3, and on down the list. All of these confer some value in terms of what your fasting triglycerides are. So let's make this more simplistic. We all get an allele from mom, we get one from dad, and let's say there are 75 genes that have some impact on triglyceride levels. If you've got, in fact, I'll come back to this in a second. I have a slide in here for this, but in fact, let me skip ahead and show that slide. Well, I guess I have it a little bit later. So if you inherit, say, 35 of those 75 genes versus 5 of them, you're much more likely to be hypertriglyceridemic. Keep in mind that each one of these polymorphisms might affect levels by 8 to 10 milligrams per deciliter. So we're looking at fasting triglycerides as really a component of multiple genes that really are additive in nature in terms of influencing levels. Now here's all the acquired causes. I mean, the list is really very long. Poorly controlled diabetes, although we've recently, I'm working with Lynn Wagernett at Wake Forest from the Look Ahead study results. And as you may recall, Look Ahead was a study where patients with type 2 diabetes underwent a weight loss protocol. And they lost a fair amount of weight in year 1. They gradually regained it over the next 10 to 11 years, but there was no benefit of weight reduction on cardiovascular disease outcomes. Now, what we've done, we went back to the baseline exam and looked at women and men in look ahead who were not on statins and not on fibrates. So back to the issue. Poorly controlled diabetes has a modest effect on fasting triglycerides. I used to think that above 7% people are getting increasingly more hypertriglyceridemic. In a population of 3,000 plus people, that slope is there. It's statistically significant, but it's weak. So although in patients with diabetes with higher levels of TGs, we want to control their glycemia more aggressively for a lot of reasons, the impact on the triglycerides is not very dramatic. Okay, back to the list. Obesity, alcohol, chronic kidney disease. Separate that from nephrotic syndrome. Nephrotic syndrome is an ugly disorder for lipid and lipoprotein metabolism. TGs go up, LDL goes up, and HDL goes down. And these people are fairly resistant to pharmacological treatment. Kidney disease is mostly TGs. Hypothyroidism, HIV, hepatocellular disease, and inflammatory diseases. Lots of disorders that make people moderately hypertriglyceridemic. Then medications, oral estrogens, we mentioned before, bile acid sequestrants, not to be used when TGs are above 300 and relatively contraindicated if they're above 250. Antiretroviral regimens, especially for HIV disease. Some phenothiazines, second-generation antipsychotics particularly. Non-selective beta blockers, thiazide diuretics, loop diuretics, glucocorticoids, immunosuppressants, tamoxifen, and vitamin A for acne. So lots of players in this acquired hypertriglyceridemia. So keep in mind, if you got 35 out of 75 genes where polymorphisms plus acquired disorders, triglyceride metabolism can go awry. And so that's the way we should think clinically. Not that one of these disorders is thiazide diuretic doesn't make a triglyceride go from 90 to 400. But if you've got many polymorphisms and your fasting TGs are 250 or 300, then adding thiazides and having poorly controlled diabetes, previous slide, might make your TGs 450 or 500. So it all depends on where you start, and I'll explain this biologically in a moment. Now here's something that I've been doing clinically, and this is an Eckel thing, so don't take this away from here as the guideline stuff. But this, I think, is correct, but I can't prove it, and I don't know that we'll ever be able to prove it. So let's think about ApoB. There's one ApoB molecule for LDL, the remnants, and also VLDL. So one molecule per particle, and assesses potentially atherogenic particle number. Okay, so the ApoB kind of tells us how many bad guys are out there in the street. Now, it helps distinguish risk of CHD in patients with hypertriglyceridemia. Now notice I'm not saying ApoB should replace lipids, because if LDL is elevated, ApoB is going to be elevated. And most ApoB is in LDL in people with normal triglycerides. But I'm talking about now patients who have hypertriglyceridemia. And you could say, well, you know, that's more expensive. Why don't you just get non-HDL cholesterol? And I'm going to show you why here just in a second. Good correlation coefficients. But remember, when coefficients are done in thousands of people, they can be very strong. But I'm sure we all take care of one patient at a time. Now, I think the real value of ApoB is in patients without increases in LDL and patients who have hypertriglyceridemia. So I'm going to show you a fairly old study, but it makes the point very well, and there's lots of literature to support this point. So this is the old phenotyping system that Fredrickson and Levy proposed in the 1950s for lipids and lipoprotein disorders. Here's a normal profile. Here are patients with isolated hypercholesterolemia with LDL only, a nearly threefold increase for events. Here's 2B, which is combined hyperlipidemia. LDL's up, triglycerides are up, but that risk is somewhat lower than pure LDL. Here's type 4, meaning just pure hypertriglyceridemia. And if we look at type 4 without any elevation in ApoB, it's no different than being normal. So that means if your triglycerides are 300 and your ApoB 65 low, there's no increased risk for cardiovascular disease. But look what Benoit Lamarche then showed if you have hyper-ApoB. Here's normal triglycerides, so this is a high LDL, basically, same risk. And here's hypertriglyceridemia with a high ApoB. The risk is identical to having a high LDL cholesterol. And here's where your HDL's low, just the HDL being low with no changes here. So this kind of data, and I use this slide again repeatedly because it's really a very nice demonstration that being hypertriglyceridemic per se, at least in the Canadian population, did not appear to be associated with risk. Now here's an important slide because it's going to support my point of taking care of one patient at a time. In the upper right, we're plotting non-HDL cholesterol, which is simply measured by subtracting the HDL from the total cholesterol. That's non-HDL. That was part of the old guideline that's now been dismissed in the new guideline. And by the way, don't throw darts. I kind of like non-HDL, but the evidence didn't support it based on the lack of evidence. Now, here's the relationship in thousands of people between non-HDL cholesterol and ApoB. Pretty convincing. But look here. If we look at a patient with a non-HDL cholesterol, this is millimolar, so 4.5, that's going to be a level of about 180 milligrams per DL. Look at this. This is a 95th percent confidence intervals for ApoB around that single level of non-HDL cholesterol. But what I want to point out here, this level is very different than this level in terms of cardiovascular disease risk. This slide doesn't show that relationship, but I can assure you if we go back to what we just covered before, these type of data, we're talking about this group right here versus this group right here. So my thought here is that ApoB may be a better way to evaluate people with hypertriglyceridemia whose LDL is low. Notice I say again, make sure you remember this, LDL has to be low. If LDL is high, ApoB is going to be high. There's no reason to measure it. So the management of TGs, is it the triglyceride only for cardiovascular disease risk? No, it's probably better non-HDL cholesterol because that takes into consideration the triglycerides. Then isn't it the triglycerides less than 150? Because keep in mind you divide by 5 when you estimate the VLDL cholesterol concentration. So that makes 150 the goal for triglycerides, not supported by the literature. Or should it be ApoB? Now again, this is simply a hypothesis that I think ApoB better defines risk and maybe should be the direction of our therapeutic intervention. All right, now let's deal with something hopefully you're not seeing very often, but I have a lot of people that are referred to the lipid clinic at the University of Colorado Hospital like this. So this is lipemic plasma. This is a normal plasma here. And basically what we're looking at is rare diseases. But rare diseases are not the cause of almost all patients like this you're seeing, and I'll return to that in a moment. So familial chylomicronemia is associated with no acquired disorders. These people have severe hypertriglyceridemia at a young age. They're at higher risk for pancreatitis, no premature heart disease. They have eruptive xanthomas, as shown here, often in the trunk, the back, around the shoulders. And also they have lipemia retinalis, shown very graphically here. Now, LPL deficiency is 1 in a million people, except for French Canadians and South Africans. There it's around 1 in 40,000. This should be the same number here. I didn't color that white, unfortunately. ApoC2 deficiency, even rarer. LMF, a processing protein defect, can cause this, and a binding protein that binds to LPO can also cause it. So these are rare diseases, and I have 7 patients with LPL deficiency that I've evaluated, and I've been at the University of Colorado for 36 years now. So, this isn't something you're going to see a lot of. But nevertheless, I'm using this as a springboard into a more important discussion that relates to patients we do see with severe hypertriglyceridemia. So the type 5 disorders defined by Frederickson Levy, basically looking back, is a genetic form of hypertriglyceridemia, and remember the genetics now, multiple genes with modest effects, plus, remember all those acquired factors. So it's kind of like 1 + 1 is 2 for a while, and then 2 + 1 is 4 and 5, plus 1 can be 8 to 10. The idea is you're saturating the removal system. So if we look at the population, these are N. Haynes data, 1999, 2008. Above 500 is where you start to think about chylomicronemia. And what we're looking at here is a prevalence of that around 1 to 2%, basically, across the population. Now here's this skewed distribution again. This is now Canadian heart health data. There's this skewing to the right. Remember, triglycerides are not bell-shaped curve. There are many more people out here than there are down here. And this is the triglycerides above the 95th percentile, which would be above 5 millimolar, which is around 450 milligrams per deciliter. Look here. Here's what we're talking about. We're talking about, again, probably a small percentage of people, again, in the range of 1 to 2% that are in that level of hypertriglyceridemia. Now, here's the slide I thought I had put earlier, and for tomorrow's talk, I will move it earlier so I don't forget where I have it. But anyway, here's the idea here. Now, if we look at control populations and we look at risk scores and we look at genes for hypertriglyceridemia, 46 versus 55, 56 versus 32, 75 versus 25, 75 versus 16, 92 versus 16, here's that gradient relationship between the alleles that we get for hypertriglyceridemia and the risk for having hypertriglyceridemia. So again, the more alleles that you receive from parents that are modified in terms of triglyceride-rich lipoprotein metabolism, the higher your TGs are. So we're looking at a 6 to 7-fold odds ratio of being higher when you have 5 times or 6 times more genes than the control group. So again, it supports this polygenic nature of hypertriglyceridemia in our patient population. Now, we're not talking now about severe hypertriglyceridemia. We're simply talking about people who walk around with TGs of 200, 250, 300. Now, my research lab has really been very interested in lipoprotein lipase, and we're looking at the enzyme more from a metabolic perspective than we are an atherosclerotic perspective. But here's LPL. It's bound to the glycocalyx here on the endothelium. The chylomicron is here. The VLDL particle is here. And part of the lipolysis reaction releases fatty acids and monoacylglycerols into tissues where the fatty acids are stored or they're oxidized, such in cardiac or skeletal muscle. Now, HDL is also formed as part of that reaction, so you transfer a lot of the surface material to HDL. So one reason there's this inverse relationship between HDL and triglycerides relates to the lipoprotein lipase reaction on the triglyceride-rich particles, getting rid of the size of the particle by hydrolyzing the core and then transferring lipid to HDL to making the particle bigger. Okay? Now, this is an important slide that takes us back to our freshman years in medical school. How many people remember Michaelis-Menten kinetics? All right. Well, Michaelis-Menten kinetics plots the enzymatic activity of enzymes, such as lipoprotein lipase, and here's the substrate concentration, plasma triglycerides. Here's a curvilinear relationship. We call this Vmax. Remember, there's only a certain amount of enzyme, and then when the substrate gets to a certain level, it tends to accumulate because you only have X amount of enzyme. Now, the Km is the value which ultimately is the concentration that 50% of the maximum enzymatic activity is there. So here's the idea. The Vmax for lipoprotein lipase is around 1,000. You could say, well, maybe it's a little higher, but if you do the math, this is kind of the way that curve looks. Here's the Km. That means the substrate concentration at which half of the enzyme is occupied. Look at this. The Km for LPL is 90. So the concept I want to build here is if you have triglycerides of 400, 500 based on your genetic profile, now acquired diseases, it doesn't take you very long to get saturated. And so severe hypertriglyceridemia in the adult patient that we see is not LPL deficiency, and it's not ApoC2 deficiency. It's the kinetics of LPL saturation, so triglycerides accumulate in the fasting plasma. So ultimately, thinking about this kinetic curve means that once people get so much triglyceride, there's no more enzyme to get rid of it. The analogy I give patients is this. If we turn on the faucet in the sink in the office and we plug the drain, the sink's going to fill up. And my question to the patient, how much water goes on the floor? And the correct answer is, how much is the faucet turned on? So that relates to the treatment of severe hypertriglyceridemia. So when triglycerides are above 1,000, we reduce dietary fat to less than 5%, no alcohol. And we correct, of course, drugs that may be causative if we can. And the question comes up, should you discontinue all triglyceride-lowering medications? That's what I do, because in saturation kinetics, the triglyceride-lowering medications don't work. So less than 5% fat relates to about a 25% lowering of triglycerides each day in the setting of saturation kinetics. So I get fasting triglycerides every 3 days until the patient's TGs are under 1,000. And if they're not falling 20 to 25% a day, they're not following the diet. And I've done this repeatedly by bringing people into the hospital and control their nutrient intake. And when we control their nutrient intake, we see that amount of lowering. And then we restart medications when triglycerides get under 1,000 because the drugs work on VLDL. They don't work on chylomicrons. And of course, the dietary fat, the chylomicrons accumulate, and that's what causes the lipemic plasma. And if triglycerides don't reach less than 1,000, then I do hospitalize these patients and I control their diet on the inpatient level. Now, keep in mind, insurance may or may not pay for that, so that's something that we have to think about. Then once the patients are between 500 and 1,000, I raise the fat content at that point because chylomicrons should be lessened to a large extent. And if the triglycerides go up on that, then I decrease the carbohydrate and increase monos and polys as the fat form in their diet. No alcohol until TGs are under 400 at least. Fiber is somewhat helpful, and sucrose in moderation are things you can do in this range to benefit the patient. So this is severe hypertriglyceridemia, something you won't see as much of as I do, but nevertheless it comes up. Now let's close in looking at the trials that relate to triglyceride lowering. Here's what we expect from medications we use to lower triglycerides. Fibrates 20 to 45%, niacin 10 to 30%, omega-3 fatty acids 15 to 35%, and statins 0 to 35%. And for statins, low-end statins do nothing. I'm talking about low-dose Prava, Fluva, even low-dose Sima doesn't do much. So we get to moderate or high-intensity statin therapy, we can get up to 35% lowering. Now here's just evidence for that. Here's a dose response curve for rosuvastatin. Here's baseline triglycerides. Here's atorvastatin. Here's simvastatin. So you see with increasing doses in this range and in this range, the amount of ultimately triglyceride lowering benefit that we do see. All right. Now, clinical trials. This is fibrate monotherapy. That means either clofibrate, gemfibrozil, bezafibrate, or fenofibrate were the drugs that were used. Here's the year these data were reported. Coronary Drug Project, WHO, Helsinki Heart, VA HIT, the BIP study, bezafibrate, approved in Europe, and the fenofibrate diabetes trial from Field in Australia. These are all monotherapy trials, all of them showing some modest benefit, although this WHO study is flawed in a lot of ways. I won't go into the details. But here's probably the most impressive result was the Helsinki Heart study. You got to realize, though, LDLs were 190, and fibrates don't lower LDL much, but they lowered it by 19% in Helsinki Heart. So this benefit was not related to the triglyceride lowering, but to the LDL lowering. VA HIT is a nice study, but keep in mind these people were selected for low HDLs and high TGs, men only. Bezafibrate, no effect. Fenofibrate in the Field study, no effect. So problematic in terms of major interpretations, and I'll just highlight VA HIT. Selected population, male only, with a pretty impressive benefit. The other thing I'll say about VA HIT is the amount of triglyceride lowering did not relate to the benefit. So the men with more TG lowering had no greater benefit than the men had less lowering. So does that mean the fibrates do something that we don't understand that improves risk? Unclear. Now here are the fibrate outcome studies evaluating high TG subgroups, and we're looking now at the HHS, the Helsinki Heart study, the Field study, diabetes only, the Accord study where fenofibrate and Simba were used in combination, and then more recently AIM High. And here's the primary endpoint. Not borderline significant, but remember, O2 is significant, but remember the LDL effect explained this. Field, NS, Accord, NS, AIM High, NS. And here are the groups that were compared, the triglycerides greater than 204, and the ratios of LDL and HDL greater than 5, TGs 204, HDL under 42, TGs above 204, less than 34, TGs above 198, less than 33, and all these give a hint of benefit. So it suggests to us that if we're treating the right kind of patients who are hypertriglyceridemic with a fibrate, we may be more expectant in terms of a positive benefit. Here's an example from the BIP trial. Baseline triglycerides relate to response. Here are people with normal triglycerides. If you use under 200 as a cut point, here's greater than 200. Pretty impressive benefit for people with hypertriglyceridemia. And here's the Accord lipid trial. These are people with type 2 diabetes. Here's the subgroup with high TGs, low HDLs, versus the group without all others in the trial. And this didn't quite make 05, but again suggests that if we're treating the right patients with fibrates, and by the way, these people were on statins. So we do have some evidence post hoc that this is relevant. So let's look at the outcomes very quickly. This is what we can conclude from the fibrate trials. They do not reduce events in high-risk patient groups, the primary outcome. The impact on hypertriglyceridemia and coronary heart disease remains unclear, but post hoc analyses do suggest that if you're hypertriglyceridemic and have a low HDL cholesterol, you're more likely to benefit. And the amount of TG lowering may not predict the benefit, and that's been shown in most of these trials. So my question to the audience here is, do you treat patients with fibrates who are not hypertriglyceridemic? I don't. And the optimal trial waits us, and the VA FIT has approved the right trial, but the VA doesn't have a lot of money right now. and remember, they were $5 billion in the hole last year. I don't think this trial is ever going to take place. But I know talking with Paul Ritker at Harvard, ultimately there's another kind of new fibrate that's being evaluated in Japan that may surface now in terms of an outcome trial in addition to statin therapy. But this trial is well designed and would have answered the question if it could have been funded. But it's been approved, but I don't think it's going to see the light of day. Let's end with omega-3s. These are largely fish oils that have long-chain fatty acids. And the one study that's always quoted, and I'll quote it here again, the JELA study, but these patients are all on low-dose pravastatin. Their LDLs at baseline or total cholesterol at baseline greater than 250, and the EPA dose relatively small. But nevertheless, total population benefit, primary prevention not beneficial, secondary prevention beneficial. But if you look at ultimately the group with hypertriglyceridemia and low HDL, there's a substantial benefit. So again, remember, omega-3 fatty acids are not FDA approved for the treatment of TGs between 200 and 500. They're only approved for TGs above 500. Now, that relates to ultimately the meta-analysis just showing fish oil supplements don't do anything, basically, for outcomes. These are 20 studies, 69,000 patients, lots of events, no benefits from supplements. But we do have 2 outcome trials that are currently recruiting and ongoing. Reduce It is using a form of EPA. This is the Amarin product, sample size 8,000. Here's the primary outcome. Expected to report in December of 2017. Again, this is in patients with TGs at 200 to 500 where an FDA approval is not present. And then the Strengths trial, which is using Vascepa, 13,000, better powered MACE. We're going to have to wait until September 2019 for that trial to report. So we have a couple of trials that are going to answer a very important question. Do high-dose omega-3s in patients who would be candidates for treatment that is not FDA approved going to benefit? So bottom line, last slide. I think we need to keep in mind lowering TGs to less than 500 reduces pancreatitis risk. And pancreatitis, one thing I think we don't really recognize, and I must admit I continue to go to the literature and get updated on this, the risk for acute pancreatitis and mortality is somewhere between 3 and 5%. As hospitalists or when I attend on internal medicine, I see people admitted with pancreatitis. Nobody dies. Everybody lives. But the thing is, what we don't see are the people who have hemorrhagic pancreatitis and die at home before they get there. Because these people go into shock, we never see them. So when I see severe hypertriglyceridemia in the clinic, I don't scare my patient, but I say, look, we got a task here that we want to get you out of a higher risk range and get that TG under 500. And I think that relates to kinetics too, that makes those triglycerides more likely to be removed more effectively and also makes drugs work better. I think initially we use current guidelines to reduce LDL. By the way, let me go tangential for just a second. I'm on the guidelines committee. I approved that it was a consensus document. I still use goal-setting behavior. So even though it may not be evidence-based, there's nothing wrong with it. So use it. But here's my suggestion. Apply the guideline for the 4 statin treatment groups. Don't forget diet and exercise, please. Okay, so make sure you do that. Indicate the 4 statin indications, yay or nay, and then qualify your goal-setting behavior and other drugs you're going to use. It's that simple. And I think you're going to get reimbursed going forward. Consider ApoB as an indicator. I'm suggesting this. I'm not making you go there, but I use ApoB as my treatment goal in hypertriglyceridemic patients in terms of cardiovascular disease risk reduction. And in patients with fasting TGs above 200 and HDLs on the low side, I'm going to use an arbitrary value of 35. Consider a fibrate or omega-3 fatty acids. I think we have enough evidence that should be a consideration we have in clinic. And I sometimes do this and I don't others. And you'd have to individualize the case. But nevertheless, I do use fibrates and omega-3s in that particular circumstance. So I'm going to stop there and thank you for your attention. See, the thing we have lots of mountains there, but I don't have any water. And as I flew into Portland yesterday, my 3 years in Seattle reminded me about great times in the past. I miss the Northwest, so you live in a great place. Questions? Laura, we can take some questions?
Yeah,
okay.
Absolutely.
Okay, over here.
Can you comment on total mortality in fibrate studies?
Total mortality in which study?
Mortality in fibrates.
Total mortality in fibrates is really questionable. I mean, in the Accord study, I don't know that there were any fibrate deaths, but women had more events than men did on the fibrate therapy versus placebo. So that ultimately is an area that's of some concern. And the FDA, when they looked at that data, wanted the VA FIT study to have 50% of their participants women. When we looked at the women in the VA, we couldn't find, but even if every woman in the VA volunteered for the study, we could only come up with 25%. But the VA refused to expand the study to include non-veterans. But total mortality, fibrates, it's really not anything we need to talk about. Yes, sir.
Can you get some of the fibrates from diet?
Fibrates from diet.
Fiber.
Oh, fiber and diet. What about fiber?
Can you get enough fiber in diet in order to
Lower triglycerides?
lower triglycerides?
Well, 25 grams or above can have a modest triglyceride lowering effect. And by the way, also lowers LDL cholesterol. So dietary fiber, I think, is part of the nutritional recommendations for heart disease prevention. So 5 or 6 servings of fruits and vegetables a day, 5 or 6 servings of whole grains a day, 1 or 2 fish servings per week. And by the way, we don't even go to sugar because if you are weight maintaining and you have that type of a diet, there's not a lot of room for discretionary calories related to simple sugar intake. So weight maintaining. I'm not saying anything about weight loss. Other questions? Is that good or bad? I don't know. Laura?
I couldn't help but be intrigued by your introduction and wondered if I could just steer it that way on some of your other work for just a second.
Okay.
Talking about kind of it seems like clinically we observe that with obesity and weight gain that often we see people reach a threshold. Once they become obese, it's very difficult
Very
to
true.
lose. Obviously a huge topic, but just curious your insights into like what's shifting there metabolically that somehow it's more complicated than calories in, calories out equation.
Yeah, the brain knows body fat content, and that's why the strategies for obesity and prevention. So as families, we raise kids, we raise grandkids, we want to maintain a healthy body weight growing up. So I think you want to prevent obesity to begin with. So that's one thing. College age is a time where there's a lot of weight gain in some students. And with women, postpartum is another time of weight gain. So we want to really emphasize during growth and development in childhood and adolescence and during college years and for women after pregnancy to get weight under control. Now, once you become obese, and this is true of the rodent data in animal models, true of the primate data, and also true of the human data, the brain senses body fat and will defend it. In fact, we did a very interesting experiment along that line. Forgive me, that sounds pretty subjective, but we did an experiment where we took walking well women who had a normal BMI, and we did a randomized controlled trial funded by the NIH where we did suction lipectomy or liposuction. There was a control group. This is the first randomized controlled trial ever done with liposuction. So the women could pick from the umbilicus down, thighs, lower abdomen, no buttocks, and they got randomized to liposuction or no liposuction. The hypothesis was in 3 years all the body fat would be regained. By the way, it all occurred in 1 year. And the body fat, when it came back, didn't come in the pelvis. It came up here, shoulders, trunk, and intravisceral. I mean, so that just is, in normal weight women, just taking 6 or 7 pounds off by liposuction surgery in 1 year, it's all back in not the best places. So now in obesity, we know with weight reduction, first of all, it's hard enough to lose weight to begin with. But after weight reduction, that recidivism, coming back to baseline, is really something that we have to experience. The strategies for weight reduction is caloric restriction. The strategies for weight maintenance is more in physical activity. So in the clinic, I don't put people through both. You need to exercise more and eat less. Now, we focus only on caloric intake. And we'll set goals for the patients in 3 months where we want them to be. And then after that, if they plateau at 3 months, plateau at 6, then we've increased physical activity going forward at 3 and 6 months. And that's a more successful story. But by the way, the weight regain that occurs after weight loss is not just behavioral. There's a biology of weight regain. And that biology relates to changes in lipoprotein lipase in tissues in terms of storage versus oxidation. It relates to insulin sensitivity, which goes up. It relates to food intake patterns. We see changes in hormones that predict more appetite. And ultimately, the natural response to weight reduction is to become less physically active. There's behavior, but yet there's a biology of returning that body weight to normal. So that's something we need to take into careful consideration. Just as an aside, and this is not triglycerides, but we have a paper coming out that shows something that happened after an anecdotal observation. So keep in mind, keep your eyes open in the clinics or in the hospital in terms of things you observe that you think may be true and kind of repeatedly observe. When fenfluramine got taken off the market, everybody remember the fen days? Some of you are too young for that, but many of us remember the fen days. I used a lot of fen. And when fenfluramine, dexfenfluramine got removed from the market, I kind of started using phentermine alone. Now, what my observation was over a decade plus was the people that responded to phentermine, by the way, easy drug to give, not very toxic, and cheap because it's generic. Although the FDA says you can only use it for 90 days. We'll come back to that. But what I observed was that if people don't eat because they're hungry, they don't respond at all to phentermine. But if they had appetite-driven food intake and they're obese, they were phentermine responders. I'm not talking about a few pounds. I'm talking about 10% or greater in almost every patient. So I created a sample which allowed us to power a study in 40 people where we used validated questionnaires looking at satiety, hunger suppression, restraint, all the kinds of things the behavioralists do. And we now were successfully capable of showing that's true. So in the clinic, so our study proved that if you don't eat because you're hungry, you're not going to respond to phentermine in a 12-week study. But if in fact you have hunger-motivated food intake, we had great responses. So I'm not pushing a drug for a company because phentermine is generic, but it's affected my practice now objectively in addition to my anecdotal experience. So think about this in the clinic a little bit. Make sure there's no contraindications. People with bad insomnia, that's not good. People who have uncontrolled blood pressure, heart rate goes up. That's true of almost all the obesity compounds, by the way. The heart rate goes up some. So you kind of got to decide whether that's worthwhile. But anyway, so the phentermine story is one now that's objectively evaluated, and I think it needs to be done for all these obesity compounds that are out there. So anyway, back to weight regulation. Body weight's regulated, so prevent excess weight gain to begin with. And once you have it, you got to work hard to keep it off long term. Not easy.
How do you
Yes, sir.
think about the very occasional patient, maybe very, very occasional patient, who loses a lot of weight and keeps it off? Is that a metabolic business? Is that a frontal lobe business? How do you understand those wonderful patients that lose a quarter of
Well,
their body weight and keep it off for a long period of time?
Well,
Those guys who practiced a long time.
yeah, Rena Wing at Brown and Jim Hill at my institution, in fact, Jim was at Vanderbilt at the time when we got Jim to come to Colorado. Anyway, they've looked at a database of some 3,000 or 4,000 people who've accomplished that. So it's not as rare as you think. And these people did it in a wide variety of different ways. Some had group therapy, some did it on their own, some had drugs. They did it a lot of different ways, not including bariatric surgery. The success was this. The long-term successful weight losers have been extremely active. We're not talking about 30 minutes 5 times a week. We're talking about 1.5 to 2 hours per day. And they're also maintaining a low-fat intake dietarily. So these are obsessive compulsive people. You could call that a personality disorder, but nevertheless, but really, these are the successful weight losers long term. Very obsessive compulsive. They get on the scale every day. By the way, I get on the scale every day. And our water weight shift. You get disappointed one day, but the point is, I want to be conscious of my weight, and so getting on the scale every day, you do it once a week. The point is, you need to be conscious about your weight. But after they've lost it, they're still doing it, and but they're extremely active. I think that's the secret. In addition to still eating less fat. Now don't misinterpret that. In terms of the obesity guidelines now, you can lose weight on any kind of diet you want. So you can lose it on Atkins. I don't favor the Atkins diet. The LDL goes up a lot. But South Beach, if you like, low carb, et cetera. So you can lose weight anyway, but keeping it off is a whole different ballgame. It's a science in its own right. So.
Matter of really changing your diet.
Well, the diet is calories. Yeah, so it's caloric intake. It's been nice being with you. Thank you. You took me into a favorite.